In a baby's head, beginning delivery smoothly during birth, but this suddenly the shoulders just. This is called shoulder dystocia, and while it sounds scary, knowing what it is and how it is managed can make a huge difference. Today we're breaking it down in simple terms. From this image, we can see that problem is usually caused by impaction of the anterior shoulder against this material symphysis. Remember that this is a bony impaction. Shoulder dystocia and predictable, but some factors increase the chance. First up, you have the pre-labor risk factors, including patients who had a previous shoulder dystocia, macromesia, diabetes, IBM, I greater or equal to 30, and induction of labor. Maternal diabetes is the most important risk factor to look out for. Increases the risk of shoulder dystocia by 2 to 4 times as much. RISC-4 will control diabetes in pregnancy in vital. Postpartum risk factors include a prolonged first stage of labor, secondary arrest, a prolonged second stage of labor, oxytocin used, and an instrumental delivery. Said that shoulder dystocia can still happen even when no risk factors are present. Now, how do we recognize shoulder dystocia? There is a four telltale signs that allow us to recognize shoulder dystocia during delivery of the head. The first is a difficult delivery of the face and chin. The next is the turtleneck signs, which refers to the head remaining title applied to the vulva or ever returning, popping in and out just like a turtle head. Another sign is a failure of resuscitation. Resuscitation refers to the normal turning of the baby's head by 90 during one's delivery to assess the delivery of the shoulder. Lastly, you would notice a failure of the shoulders to descend. So if you see these signs of obstetric, team should be on the alert for a possible shoulder dystocia. Now probably the most important part, the management. Shoulder dystocia is one of the most serious obstetric emergencies. We've got an acronym called HERBERT to help our healthcare professional act fast and remember all these tips. Let's break it down. So H for help. Managing shoulder dystocia is a team effort. We need to ascertain state shoulder dystocia for everyone in the room to be aware of what we are dealing with. Like we said this in obstetric emergency, we need all hands on deck. Evaluate for obesity. And obesity should be considered to give more space for entering maneuver. But remember, this is a bony obstruction too, so in obesity is not going to help to directly free the shoulder. L legs macropetis manforce and B suprapubic process. So the first manforce is the macropetis manforce. It works 90% of the time. It involves flexing and abducting mother legs. Early you have to individual holding either leg. It helps increase the anteroposterior diameters of the pelvis to free the baby's shoulders. It's important that woman is laid completely flat, so the pillow should remove it before performing the manfor analyte, which we've got going on. Now suprapubic pressure reverse to firm pressure applied just above the pubic bone on the side of the fetal back to push down on the posterior aspect. This is performed by a separate team member, unlike what is being ported in this image. Now to understand where the back is, you must look at the direction the baby has and assume the back on the opposite side of course. So in this case, the baby's head is facing us and a midwife is applying downward a little pressure on the opposite. Whenever a maneuver is performed, someone in the team is trying to deliver the baby by applying axial traction to the is traction in line with the fetal spine. This is performed for approximately 30 seconds, and if it doesn't work, we move on to the next man. Next we got E, intersinifying, to enter the vagina for the interim maneuver. First, we got the wood screw maneuver, which involves applying pressure on the posterior aspect of the anterior shoulder and on the anterior aspect to posterior shoulder to turn the baby. Then we got the reverse wood screw. This involves applying pressure on the posterior aspects of the posterior shoulder and dropping to which involves pressure on the posterior aspect to the posterior anterior shoulder. The order is not strict and of course space in issue, So whatever you manage to do it. Essentially here we grasp to the rest of the posterior arm and try to deliver it gently. Some obstetricians prefer starting with this internal maneuver. Lastly, we got to roll the patient on all fours. So essentially, we tried to performing the same maneuver, but this time in an all fours position. If that doesn't work, we start over until we manage. Now, in some rare cases, if we still not manage to deliver the shoulder, we can opt for a clyte, which involves fracturing the baby's clavicle to reduce the episiotomal diameter and deliver the which involves positioning the baby head back inside the uterus and performing the cesarean section to deliver the baby, or else symphysiotomy, dilating the maternal symphysis babies to allow for more space. Of course, these are all last resort maneuver and are associated severe morbidity and mortality once you've gotten over dealing with the trauma of the shoulder dystocia is not. You need to look out for the associated complications. Postpartum hemorrhage occurs in 11% of cases. Perinatal is also common, occurring in 3.8% of cases. And due to the excessive traction on the baby, there is also a risk of brachial plate injuries, which should appropriately check it. And thank you.